Hello, future nurses. Welcome back. Today, we're jumping into one of the most important NCLEX topics, pharmacology questions related to the respiratory system. These meds come up again and again on the boards, so stay with me through this full session and boost your chances of passing in one try. But before we dive in, I have something truly game-changing to share with you. We've created a complete NCLEX crash course, a proven shortcut to help you pass the exam in just 7 days or 1 month. Thousands of students have already enrolled and passed on their first attempt. And if you don't join now, you might fall behind while others move ahead. Here's what you get inside the course: 100 hours of fast-track animated lessons, 500 hours of recorded lectures covering 500-plus high-yield NCLEX topics, 5,000 previously asked NCLEX questions, 15 full-length CAT-style mock tests, a powerful NCLEX eBook, and a limited-time 70% discount. Visit our website to enroll now. The link is also given in the description box below. Let's make NCLEX success fast, simple, and guaranteed. All right. Let's get started with today's NCLEX Pharmacology quiz on the respiratory system. Let's see how well you do. Let's dive into our very first question. The nurse is reviewing a set of newly prescribed medications for 4 assigned clients during the morning shift. Based on pharmacological knowledge and patient safety, which of the following prescriptions should the nurse question and clarify with the healthcare provider for administration? Now, here are the answer choices to consider. Option A, albuterol via nebulizer, prescribed for a client currently experiencing moderate hypokalemia. Serum potassium, 3.1 milliequivalents per liter. Option B, clozapine prescribed for a client with treatment-resistant schizophrenia and stable white blood cell counts. Option C, lisinopril prescribed for a client diagnosed with congestive heart failure and an ejection fraction of 35%. Option D, verapamil prescribed as prophylactic therapy for a client with frequent migraine attacks. After analyzing the options, the correct answer is A, albuterol via nebulizer for a client with hypokalemia. Let's break down the rationale to understand why. Albuterol, a short-acting beta-2 agonist, SABA, is commonly used for acute bronchospasm in asthma, or COPD. However, a critical side effect is hypokalemia due to intracellular potassium shift caused by beta-adrenergic stimulation. Administering albuterol to a client with pre-existing hypokalemia can dangerously exacerbate the electrolyte imbalance, potentially precipitating cardiac arrhythmias such as ventricular tachycardia or fibrillation. Nursing action. This prescription should be questioned. The nurse must report the current potassium level to the provider, monitor for signs of hypokalemia, e.g., muscle weakness, ECG changes like U waves, and advocate for potassium correction prior to administration if bronchodilation is still necessary. NCLEX. Tip: when a prescribed drug worsens a client's abnormal lab value or underlying condition, the nurse must intervene before administration. Why the other options are wrong. Option B, clozapine is an atypical antipsychotic, effective for treatment-resistant schizophrenia. While it carries a risk for a granulocytosis, it is not contraindicated if the client has stable ANC, absolute neutrophil count levels, and is under regular hematological monitoring per FDA REMS guidelines. Nurses must educate clients on signs of infection and ensure routine weekly to monthly blood work is done. Option C, lisinopril is a first-line ACE inhibitor for heart failure and hypertension. It reduces afterload, prevents ventricular remodeling, and improves survival in clients with reduced ejection fraction. Monitor for hypotension, dry cough, and hyperkalemia, but the prescription is appropriate. Option D, verapamil, a calcium channel blocker, is frequently prescribed for migraine prophylaxis, especially in clients who cannot tolerate beta blockers. It also helps in hypertension and rate control in atrial fibrillation. Nurses should assess for bradycardia, constipation, and orthostatic hypotension, but this use is evidence-based and does not warrant questioning. Let's begin with the second clinical scenario. A nurse is caring for an adult client who reports persistent nasal congestion despite frequent use of an over-the-counter intranasal decongestant spray. The client states, "It felt better at first, but now my nose feels even more blocked." What is the most appropriate nursing instruction at this time? Here come the available options to choose from. A. Discontinue the medication for several days to allow nasal tissues to recover. B. Begin alternating between intranasal and oral decongestants for more effective relief. C. Switch to a higher potency formulation of the same decongestant. D. Increase the frequency of the decongestant spray to overcome tolerance. The right answer to this question is A. Discontinue the medication for several days to allow nasal tissues to recover. Let's explore the reasoning behind it in detail. Choice A is correct. This scenario is a classic example of rhinitis medicamentosa, also known as rebound congestion, caused by prolonged use of topical nasal decongestants, typically containing oxymetazoline or phenylephrine. These agents act as alpha-adrenergic agonists, promoting vasoconstriction of nasal mucosal vessels. However, when used for more than 3 to 5 days, the body compensates through vasodilation, leading to worsened nasal stuffiness once the medication wears off. The safest and most effective intervention is to discontinue the decongestant entirely, allowing nasal mucosa to recover naturally over 2 to 3 weeks. Nurses play a crucial role in educating clients about appropriate medication usage and preventing iatrogenic complications from overuse. Choice B is incorrect. Combining topical and systemic decongestants is not recommended without a physician's evaluation, especially when a rebound effect is already suspected. Systemic decongestants may worsen cardiovascular conditions and are contraindicated in hypertension, hyperthyroidism, diabetes, and coronary artery disease. Additionally, nurses must not prescribe or recommend alternative medications without provider input. Choice C is incorrect. Increasing the strength of the decongestant will not solve the problem and may exacerbate mucosal rebound and systemic side effects such as hypertension, tachycardia, nervousness, and insomnia. This promotes a dangerous cycle of dependency without addressing the underlying issue. Choice D is incorrect. Increasing frequency of use only worsens rebound congestion and delays recovery. Frequent exposure intensifies the inflammatory response, making long-term healing more difficult. Additional pharmacological and pathophysiological insights for nurses. Mechanism of action of nasal decongestants. Stimulate alpha-1 adrenergic receptors in the nasal mucosa, vasoconstriction, reduced blood flow, decreased swelling and mucus production. Common agents: oxymetazoline, phenylephrine. Side effects: local, rebound congestion, dryness, irritation. Systemic: increased heart rate, elevated blood pressure, restlessness. Client teaching points: use only as directed, not more than twice daily, for a maximum of 3 to 5 days. Seek provider evaluation if symptoms persist beyond 5 to 7 days. Report side effects, such as palpitations or dizziness. Special caution for clients with hypertension, cardiac disease, hyperthyroidism, diabetes mellitus. Here comes next question. A pediatric client is admitted with a diagnosis of laryngotracheobronchitis, croup. The nurse notes the following assessment findings during the night shift: progressively worsening inspiratory stridor, increased restlessness, mild intercostal retractions, and an oxygen saturation of 92% on room air. The child is alert but irritable and has a barking cough. The healthcare provider has not yet prescribed any respiratory medications. Based on this clinical presentation, which immediate pharmacologic intervention should the nurse anticipate requesting from the provider to rapidly reduce airway inflammation and prevent potential respiratory failure? A. Administer formoterol via dry powder inhaler. B. Administer nebulized racemic epinephrine via nebulizer. C. Initiate albuterol nebulization. D. Administer oral montelukast. Correct answer is B. Administer nebulized racemic epinephrine via nebulizer. Rationale and clinical reasoning. Option B is correct. Nebulized racemic epinephrine is the first-line emergent treatment for moderate to severe croup. It acts by causing vasoconstriction in the mucosal vessels of the upper airway, thereby reducing edema and rapidly improving airflow and stridor. It works within minutes and is administered via nebulizer over 15 minutes and can be repeated in 15 to 20 minutes if needed. This intervention is critical in preventing acute upper airway obstruction, which is the most life-threatening complication of croup. Here are additional nursing considerations. Monitor for rebound stridor after epinephrine wears off. Continuous cardiopulmonary monitoring is essential due to potential side effects like tachycardia and hypertension, often co-administered with corticosteroids, e.g. dexamethasone, for longer-lasting anti-inflammatory effects. Why the other options are incorrect. A. Formoterol. This is a long-acting beta-2 agonist used only for maintenance therapy in chronic asthma or COPD, not for acute or emergent situations like croup. It also has no effect on upper airway inflammation, which is the primary pathology in croup. C. Albuterol, a short-acting beta-2 agonist. Albuterol targets lower airway bronchospasm, making it useful in asthma or bronchiolitis, not upper airway conditions like croup. Since croup involves subglottic edema, not bronchospasm, albuterol has minimal benefit. D. Montelukast. This leukotriene receptor antagonist is a preventive medication for chronic allergic asthma and exercise-induced bronchospasm. It has no role in acute airway inflammation and is not effective in treating viral croup. Here are enriching clinical insights. Croup is typically caused by viral infections, most commonly parainfluenza virus, but also RSV, influenza, and adenovirus. Classic signs include barking cough, inspiratory stridor, and hoarseness, worsening stridor at rest. Decreased oxygen saturation and agitation suggest impending airway compromise and require urgent pharmacologic and supportive interventions. Now let's discuss the fourth question. A client diagnosed with acute bronchitis has been prescribed guaifenesin. During a discharge teaching session, which client's statement demonstrates the most accurate understanding of the therapeutic action and nursing considerations related to this medication? A. This medication will help reduce my fever. B. I'll take this medication to relieve my cough and loosen mucus. C. I should take this medication with a meal to prevent stomach upset. D. I'll need to avoid drinking fluids while taking this medication. Correct answer is option B. I'll take this medication to relieve my cough and loosen mucus. Now we will see the rationale for this. Option B is correct. Guaifenesin is classified as an expectorant, commonly used in the treatment of productive cough associated with respiratory tract infections like bronchitis or the common cold. Its primary mechanism is to reduce the viscosity of mucus by increasing respiratory tract fluid secretions. This makes mucus thinner and easier to mobilize via coughing. When educating clients, it is essential to emphasize that this medication is designed to assist in mucus clearance, not suppress the cough reflex entirely. Here is important nursing tip. Nurses should advise clients to increase fluid intake unless contraindicated, for example, in cases of heart failure or renal disease, to enhance the medication's mucolytic effect. Option A is incorrect. While guaifenesin may be included in combination cold medications that contain antipyretics, like acetaminophen, guaifenesin alone does not reduce fever. It does not have antipyretic, anti-inflammatory, or analgesic properties. Fever management requires a different pharmacologic approach. Option C is incorrect. Although some clients may experience mild gastrointestinal discomfort, guaifenesin does not require administration with food. Taking it with meals may minimize nausea, but this is not a universal recommendation. The emphasis in teaching should instead be placed on hydration and proper dosing intervals. Option D is incorrect. This choice is dangerously incorrect and reflects a common misconception. Fluids are actually essential when taking guaifenesin. Adequate hydration helps liquefy mucus, enhances drug effectiveness, and supports airway clearance. Restricting fluids could reduce the therapeutic benefits of the medication and lead to mucus retention. Additional clinical pearls for nurses. Hydration is key. Clients should be taught to maintain good fluid intake unless medically restricted. Dosage timing. Guaifenesin is often dosed every 4 to 6 hours. Nurses should reinforce adherence to dosing schedules. Sedation consideration. Although rare, some formulations may cause drowsiness, especially if combined with antihistamines. Client teaching. Let clients know to monitor for changes in cough character and seek care if cough persists beyond 7 days, as this may signal a secondary infection or complication. Avoid self-medication with multiple OTCs. Many cold and flu products include guaifenesin. Inadvertent overdosing is a risk. Now we will discuss next question. A neonatal nurse is managing the care of a premature infant born at 29 weeks of gestation who is exhibiting signs of respiratory distress syndrome. The nurse anticipates a prescription for a medication that directly supplements the underdeveloped pulmonary system and compensates for the deficiency of endogenous surfactant. Which of the following medications should the nurse expect to be prescribed as a direct surfactant replacement therapy to improve alveolar stability in this newborn? A. Theophylline. B. Poractant alpha. C. Dexamethasone. D. Albuterol. Correct answer is option B. Poractant alpha. Let's see why this option is correct. Poractant alpha is a natural surfactant preparation derived from porcine lungs, administered via intratracheal instillation in preterm neonates diagnosed with RDS. Surfactant plays a crucial role in reducing surface tension within the alveoli, thereby preventing alveolar collapse, atelectasis, during exhalation. Preterm infants, especially those born before 32 to 34 weeks, often lack adequate surfactant production due to immaturity of type 2 alveolar cells. Early administration of poractant alpha in neonates significantly improves oxygenation, decreases the incidence of pneumothorax, and reduces neonatal mortality. Incorrect options and their evidence-based justifications. Option A. Theophylline. Theophylline is a methylxanthine derivative that acts as a bronchodilator and central respiratory stimulant, typically used in older pediatric patients or adults with asthma, COPD, or apnea of prematurity. However, it does not impact surfactant production or replace surfactant and is not a frontline agent in the management of neonatal RDS. Option C. Dexamethasone. Dexamethasone is a potent corticosteroid. While antenatal corticosteroids, such as dexamethasone or betamethasone, are administered to mothers at risk for preterm labor prior to delivery, their goal is to stimulate fetal lung maturity and promote endogenous surfactant production. However, once the infant is born and diagnosed with RDS, postnatal corticosteroids are not used as first-line treatment due to risk of neurodevelopmental delays and impaired growth. In specific cases, postnatal dexamethasone may be used to wean from mechanical ventilation or prevent chronic lung disease, but it does not serve as a surfactant substitute. Option D. Albuterol. Albuterol is a short-acting beta-2 adrenergic agonist used to manage acute bronchospasm in asthma and reactive airway diseases. It is not appropriate in neonatal surfactant deficiency, as it does not influence surfactant synthesis or function, and is not recommended in the treatment of RDS in newborns. Critical thinking point for nurses that you should keep in mind. When managing preterm infants with RDS, the priority is to ensure adequate alveolar expansion and oxygenation through both mechanical ventilation support and exogenous surfactant administration. Nurses play a vital role in preparing for surfactant delivery via endotracheal tube, monitoring the infant for oxygen saturation changes, lung compliance, and signs of pneumothorax or adverse reactions following surfactant therapy. Now we will discuss next question. The nurse is reviewing asthma home management instructions with the parents of a 10-year-old child recently prescribed formoterol for persistent moderate asthma. Which parent statement reflects an accurate understanding of the medication's purpose, usage, and side effects? A. We'll give this medication as soon as our child starts wheezing to stop the asthma attack. B. After each dose of this inhaler, my child will rinse their mouth out to avoid getting an oral infection. C. We'll monitor our child's sleep because this medication might cause trouble falling asleep. D. We'll have our child take this medication 2 hours before gym class to prevent exercise-induced symptoms. Correct answer is option C. Here is rationale behind this. Formoterol is a long-acting beta-2 adrenergic agonist, ELABA-A, used for long-term control of asthma, not for rescue during acute bronchospasm. LABAs stimulate adrenergic receptors, which can cause systemic effects such as nervousness, palpitations, and insomnia. Therefore, insomnia is a common side effect due to sympathetic nervous system stimulation, and monitoring sleep patterns is appropriate. Option A is incorrect. LABAs like formoterol do not provide immediate relief during an asthma attack. Short-acting beta agonists, SABAs, like albuterol, are used for acute bronchospasm. Administering formoterol during an attack would delay appropriate care and could be dangerous. Option B is incorrect. Rinsing the mouth is essential after inhaled corticosteroids, e.g., fluticasone, budesonide, to reduce the risk of oropharyngeal candidiasis, but not required after using a LABA like formoterol, as it is not immunosuppressive locally. Option D is incorrect. While formoterol has a rapid onset, within minutes, its primary role is maintenance therapy. It is not the preferred drug for exercise-induced bronchospasm. Agents such as SABAs or leukotriene receptor antagonists like montelukast are typically used 30 minutes to 2 hours before exercise in clients with EIB. Clinical insight for nurses. Always differentiate between maintenance versus rescue medications. Teach caregivers about side effect monitoring, for example, sleep disturbances, tachycardia. Reinforce that LABAs must be taken regularly, not PRN. Pairing LABAs with corticosteroids is common to reduce inflammation and improve control. Here is test-taking strategy. Tip: when the question asks which statement indicates understanding, eliminate options involving incorrect timing, administration technique, or drug class confusion. Focus on pharmacological action and nursing teaching priorities. Now let's discuss next question. A nurse is evaluating the therapeutic effectiveness of guaifenesin in a client diagnosed with acute bronchitis. The client reports increased ease in expectorating mucus, but continues to have intermittent coughing episodes. Which of the following clinical observations would best indicate that guaifenesin is producing the desired pharmacological effect? A. Decreased frequency of coughing with thick sputum production. B. Subjective improvement in nasal congestion and watery eyes. C. Increased liquefaction and thinning of bronchial secretions. D. Resolution of cough with complete cessation of mucus production. Correct answer is option C. Increased liquefaction and thinning of bronchial secretions. Here is detailed clinical rationale for this. Option C is correct because guaifenesin is classified as an expectorant, and its primary therapeutic action is to reduce the viscosity of respiratory secretions by increasing hydration of the mucus. This facilitates mucociliary clearance by making secretions easier to expectorate through coughing. The nurse should assess for signs that the mucus is becoming less tenacious and more easily expelled, which confirms the drug's expected effect. Why the other options are incorrect. Option A, decreased frequency of coughing with thick sputum. Although less coughing may seem favorable, this response does not confirm that guaifenesin is effective, as it does not address the mucus consistency. Guaifenesin does not suppress cough reflexes. That is the role of antitussives like benzonatate or dextromethorphan. Option B, subjective improvement in nasal congestion and watery eyes. These are hallmark antihistamine effects, not expectorant effects. Drugs like diphenhydramine or loratadine would be used in that context, not guaifenesin. Option D, resolution of cough with complete cessation of mucus production. Guaifenesin does not stop mucus production or coughing. Rather, it enhances airway clearance by thinning secretions. A sudden halt in mucus or cough may actually indicate airway obstruction or disease progression in some cases. Additional pharmacological and nursing knowledge for NCLEX. PrEP. Mechanism of action. Guaifenesin acts on the respiratory tract glands, stimulating an increase in the volume of secretions and decreasing viscosity. Nursing responsibilities. Encourage oral fluid intake, unless contraindicated, to promote mucus thinning. Monitor sputum characteristics, color, consistency, and volume to evaluate drug effectiveness. Educate the client that coughing may persist but should become more productive. Assess for potential side effects, nausea, vomiting, or dizziness. Common use, frequently found in over-the-counter cold cough preparations and often combined with antitussives or decongestants. Patient education. Advise clients that guaifenesin will not stop the cough, but rather help make the cough more effective at clearing mucus. Let's discuss question number 8 dash. A nurse is caring for a 16-year-old client with cystic fibrosis who presents with labored breathing, productive cough of thick sputum, and decreased oxygen saturation. The healthcare provider prescribes nebulized acetylcysteine as part of the respiratory care regimen. Which of the following best explains the primary therapeutic mechanism of acetylcysteine in this clinical context? A. Reduces airway inflammation by inhibiting leukotriene synthesis, thereby improving airflow resistance. B. Facilitates bronchodilation by competitively antagonizing muscarinic receptors in bronchial smooth muscle. C. Enhances mucociliary clearance by breaking disulfide bonds in mucus, thus decreasing its viscosity. D. Protects pulmonary tissue by scavenging reactive oxygen species and reducing oxidative damage. Correct answer, option C, enhances mucociliary clearance by breaking disulfide bonds in mucus, thus decreasing its viscosity. Rationale and advanced nursing insights. Option C is correct. Acetylcysteine is a mucolytic agent primarily used to treat clients with abnormally thick mucus, particularly in conditions like cystic fibrosis, chronic bronchitis, and COPD. It works by disrupting the disulfide bonds in mucoproteins, which are responsible for the elasticity and viscosity of mucus. This breakdown liquefies mucus, facilitating easier expectoration and promoting more effective airway clearance via the mucociliary escalator. In cystic fibrosis, thick, tenacious mucus is a hallmark feature that obstructs airways, promotes infection, and worsens gas exchange. Thus, enhancing mucociliary clearance is the most critical therapeutic target in this case. Option A is incorrect. While leukotriene inhibition is a mechanism of drugs like montelukast, acetylcysteine does not significantly inhibit leukotriene synthesis. It may have minor anti-inflammatory or antioxidant roles, but these are not its primary mechanism in the treatment of CF. Option B is incorrect. Acetylcysteine does not act as a bronchodilator. Bronchodilation is typically achieved with beta-2 agonists, e.g., albuterol, or anticholinergics, e.g., ipratropium, which directly affect airway smooth muscle tone. Although acetylcysteine is sometimes co-administered with bronchodilators to reduce the risk of bronchospasm, it does not provide this effect itself. Option D is incorrect. While acetylcysteine does possess antioxidant properties, especially in IV form for acetaminophen overdose, this is not the primary reason for its use in cystic fibrosis. In the pulmonary setting, its mucolytic action is the key clinical benefit. Additional high-yield nursing considerations. Encourage increased fluid intake, unless contraindicated, to assist in thinning mucus and supporting clearance. Monitor for bronchospasm during nebulized administration. A short-acting bronchodilator, e.g., albuterol, may be given prior to acetylcysteine to prevent this. Assess the client's sputum characteristics, oxygen saturation, and respiratory effort before and after treatment. Document improvements in ease of breathing, sputum clearance, and respiratory rate as indicators of drug efficacy. Now we will move to question number 9. A nurse is evaluating a 12-year-old client with a history of asthma and seasonal allergic rhinitis who has recently been prescribed montelukast, singular. During a follow-up assessment, which of the following client-reported symptoms should the nurse identify as the most concerning and indicative of a serious adverse effect requiring immediate provider notification? A. I've had a few headaches, but they go away on their own. B. Sometimes I feel like people are talking to me when no one is there. C. My bowel movements have become less frequent lately. D. It's getting harder to start urinating sometimes. Correct answer, B. Sometimes I feel like people are talking to me when no one is there. Clinical judgment and rationale. Option B is correct because hallucinations are a neuropsychiatric adverse effect associated with montelukast. This leukotriene receptor antagonist, though commonly used to prevent asthma exacerbations and treat allergic rhinitis, has been linked to rare but serious psychiatric symptoms, including hallucinations, suicidal ideation, agitation, anxiety, sleep disturbances, and depression, particularly in pediatric and adolescent populations. Nursing priority. The nurse must recognize that neuropsychiatric changes, especially hallucinations, warrant immediate provider notification and discontinuation of the drug. Early detection is crucial to prevent worsening symptoms or harm to the client. Option A is incorrect because headaches can be a common mild side effect of montelukast, but are not usually serious. Monitoring is warranted, but this symptom is not emergent. Option C is incorrect, as constipation is not a known adverse effect of montelukast. GI changes like abdominal pain may occur, but constipation is neither typical nor concerning in this context. Option D is incorrect because urinary retention is more commonly associated with anticholinergic medications, e.g., tricyclic antidepressants, antihistamines, and not montelukast. This symptom is unrelated to the expected adverse profile of this drug. Additional NCLEX critical teaching points. Montelukast should be taken in the evening if prescribed for chronic asthma and 2 hours before exercise, if used for exercise-induced bronchospasm. Families should be educated on early signs of behavioral or mood changes and advised to report them without delay. The FDA has issued warnings about neuropsychiatric effects, and nurses play a vital role in medication safety by early identification and education. Now we will discuss next question. An 80-year-old female client with a chronic history of asthma is currently hospitalized for an acute exacerbation. The provider has prescribed theophylline, and the next dose is due. As the primary nurse, which assessment finding should take highest priority before administering the next dose? A. Monitor for febrile episodes. B. Evaluate current blood pressure readings. C. Assess recent urinary output pattern. D. Check pulse rate and rhythm for abnormalities. Correct answer. D. Check pulse rate and rhythm for abnormalities. Here's the rationale for this. Theophylline has a narrow therapeutic index, meaning small changes in blood levels can cause toxicity. One of the most critical adverse effects of theophylline toxicity is cardiac arrhythmias. Before administering the next dose, the nurse must assess the client's pulse rate and rhythm, which are early indicators of possible toxicity. A rapid, irregular, or unusually strong pulse may signal the onset of supraventricular tachycardia, atrial fibrillation, or other arrhythmias, all of which can be life-threatening in elderly patients, especially those with underlying respiratory disease. If pulse irregularities are detected, withholding the dose and immediately notifying the healthcare provider is required. Choice A is incorrect. Although monitoring temperature is a general part of patient assessment, it is not a primary concern with theophylline administration. The drug does not commonly cause fever or affect thermoregulation directly. Choice B is incorrect. While theophylline may affect blood pressure indirectly through its cardiovascular effects, significant hypotension is not a primary indicator of toxicity. Therefore, it is not the first vital sign that warrants assessment. Choice C is incorrect. Urinary output is not a reliable marker of theophylline toxicity. The drug is metabolized primarily by the liver and excreted by the kidneys, but toxicity presents more urgently with neurological and cardiovascular symptoms than renal alterations. Nursing priority. Reminder: before administering theophylline, always assess for signs of early toxicity, cardiac symptoms, tachycardia, arrhythmias, neurological changes, restlessness, seizures, gastrointestinal symptoms, nausea, vomiting. Here is important clinical tip. Serum theophylline levels should be maintained between 10 to 20 micrograms per milliliter. Levels above 20 micrograms per milliliter increase the risk for serious adverse events, such as status epilepticus and ventricular arrhythmias. Now let's discuss question number 11th. A nurse is reviewing a provider's order for ipratropium bromide inhalation therapy for a client diagnosed with chronic obstructive pulmonary disease. Which of the following best describes the primary therapeutic effect of this medication? A. Enhances coronary artery perfusion to improve oxygenation. B. Reduces histamine-mediated inflammatory responses in the lungs. C. Promotes bronchodilation by relaxing airway smooth muscle. D. Inhibits parasympathetic stimulation through muscarinic receptor blockade. Correct answer. C. Promotes bronchodilation by relaxing airway smooth muscle. Rationale for this is here. The primary therapeutic action of ipratropium bromide is to relax bronchial smooth muscle, leading to bronchodilation, which improves airflow and decreases airway resistance. This effect is especially beneficial in managing bronchospasm in COPD and, in some cases, asthma. Option A, incorrect. Ipratropium has no direct effect on coronary vasodilation. It is not used to manage cardiovascular conditions or improve coronary perfusion. Option B, incorrect. Ipratropium does not inhibit histamine release. That action is characteristic of antihistamines or mast cell stabilizers, not anticholinergic bronchodilators. Option D, incorrect but closely related. While ipratropium does block muscarinic receptors, specifically M3 receptors in the airway, this represents its mechanism of action, not its therapeutic effect. The mechanism leads to reduced vagal tone, preventing bronchoconstriction, which ultimately results in bronchodilation, the therapeutic benefit. Clinical pearls for NCLEX nurses. Ipratropium bromide is a short-acting anticholinergic SAMA used primarily for maintenance therapy in COPD, not for acute asthma attacks. Assess baseline and post-administration respiratory parameters, such as lung sounds, respiratory rate, pulse oximetry, and peak flow if applicable. Inhaled via MDI, metered dose inhaler, or nebulizer. Educate patients to rinse their mouth after use to avoid dryness or bitter taste. Caution in clients with glaucoma, urinary retention, or BPH, due to anticholinergic side effects. Now we will discuss next question. A nurse is conducting a home visit for a client recently diagnosed with moderate chronic obstructive pulmonary disease who has been prescribed tiotropium bromide inhalation capsules via a HandiHaler device. During the assessment, which client behavior should prompt immediate nursing intervention due to a potential safety concern? A. The client mentions discarding unused tiotropium capsules in the kitchen trash can along with other household waste. B. The client reports giving 2 unused tiotropium capsules to a relative who also has COPD and ran out of theirs. C. The client demonstrates medication administration while reclining in bed, but states, "I usually sit up when I'm not so tired." D. The client stores the unopened blister pack in a sealed container in a drawer, away from direct heat or sunlight. Correct answer, B. Medication. Sharing is dangerous and unethical. Let's us see rationale behind this. Medication sharing is dangerous and unethical. This is the most significant safety red flag. Tiotropium is a prescription-only, long-acting anticholinergic bronchodilator meant for maintenance therapy in COPD. Sharing it, even with another person diagnosed with COPD, is unsafe because it bypasses individualized assessment. Dose, comorbidities, contraindications. It may lead to underdosing, overdosing, or drug interactions. It violates medical and legal guidelines for prescription medication use. It puts the original client at risk for medication, non-adherence, or depletion. CDC data shows that 1 in 6 adults admit to sharing medications, a practice that can contribute to adverse drug events, treatment failure, and legal issues. Incorrect option A. Improper but not immediate danger. While not the best disposal practice, household trash is not immediately unsafe unless there's a risk of accidental ingestion by children, pets, or misuse. Nurses should teach proper disposal methods, e.g., take-back programs, but it doesn't warrant immediate intervention in most adult-only households. Incorrect option C. Suboptimal technique, not critical. Inhaling while lying down may reduce medication efficacy due to gravity and suboptimal lung expansion, but it does not present an immediate safety concern. Reinforcement of technique is important, but this is a teaching moment, not a red flag. Incorrect option, D. Correct storage technique. This behavior reflects safe medication handling. Tiotropium capsules should remain in their blister packs until use and stored in a cool, dry place to avoid degradation, moisture exposure, or contamination. This is ideal practice. Additional clinical insights for nurses. Tiotropium bromide is not a rescue medication and should never be used for acute bronchospasm. Ensure clients understand this distinction. Inhalation devices like the HandyHaler require coordinated teaching. The capsule must be pierced properly, and the patient must inhale deeply and completely. Common side effects include dry mouth, headache, constipation, and tachycardia. Serious adverse effects include worsening of glaucoma and urinary retention. Moving to next question. A nurse is caring for a critically ill adult client who is intubated and receiving mechanical ventilation in the ICU. The primary healthcare provider has written several new medication prescriptions. Which prescription should the nurse question the least, knowing it directly addresses a major complication associated with prolonged mechanical ventilation? A. Hydroxyzine 25 milligrams intravenous every 6 hours as needed for restlessness. B. Pantoprazole 40 milligrams intravenous daily. C. Rivastigmine 3 milligrams orally twice daily. D. Verapamil 80 milligrams orally 3 times daily. Correct answer. B. Pantoprazole 40 milligrams intravenous daily. Let's see clinical reasoning and rationale behind this. Option B is correct. Because pantoprazole, a proton pump inhibitor, is appropriately prescribed to prevent stress-related mucosal disease, commonly referred to as stress ulcers, which are a known complication in critically ill clients, particularly those on mechanical ventilation for greater than 48 hours. These ulcers result from increased gastric acid secretion and reduced mucosal blood flow during physiological stress. Stress ulcers may lead to upper gastrointestinal bleeding, perforation, and hypovolemic shock if left unaddressed. Therefore, acid suppression therapy using a PPI, for example pantoprazole, or an H2 receptor antagonist, like famotidine, is considered standard prophylactic management. Nursing priority. Monitor for signs of gastrointestinal bleeding, such as occult blood in stools, melena, hematemesis, hypotension, and unexplained anemia. Watch for long-term PIUs may increase the risk of ventilator-associated pneumonia due to gastric colonization and aspiration. Option A. Hydroxyzine. Hydroxyzine is an antihistamine with anticholinergic, sedative, and anxiolytic properties. It is typically used for anxiety, nausea, or allergic reactions. It is not commonly used in ventilated patients due to its sedating effects and potential to depress respiratory drive further, especially if weaning from the ventilator is anticipated. Option C. Rivastigmine. Rivastigmine is a cholinesterase inhibitor used to slow cognitive decline in Alzheimer's and Parkinson's disease dementia. It is not relevant to the acute management of a ventilated patient and has no role in stress ulcer prevention. Also, it would not be administered to an intubated client unless part of ongoing home medication. Option D. Verapamil. Verapamil is a calcium channel blocker indicated for hypertension, angina, and arrhythmias. It can cause hypotension and bradycardia, which may be detrimental in a critically ill ventilated patient unless specifically indicated for rhythm control. It does not address stress ulcer risk and would not be anticipated as routine care for ventilated patients. Here are advanced nursing considerations. Mechanical ventilation greater than 48 hours is a trigger for gastrointestinal prophylaxis orders. Proton pump inhibitors are typically preferred over H2 blockers for more potent acid suppression. GI bleeding in ventilated patients significantly increases mortality risk. Monitor gastric residual volumes, abdominal distension, and GI output, especially in sedated and intubated patients, as early signs of stress ulcer may be subtle. Now we will discuss 14th question. A nurse is reviewing medication instructions with a client diagnosed with chronic obstructive pulmonary disease who has been newly prescribed tiotropium bromide via inhalation. Which of the following statements made by the client indicates the correct understanding of this medication? A. I will use this inhaler once daily in the morning at the same time. B. If I feel more short of breath during the day, I should use an extra dose. C. I need to keep this inhaler in the refrigerator so it stays effective. D. I should prime the inhaler by spraying it into the air before each dose. Correct answer, A. I will use this inhaler once daily in the morning at the same time. Here is rational tiotropium bromide is a long-acting anticholinergic bronchodilator indicated for maintenance therapy in COPD, not for acute exacerbations. It is designed for once daily use, ideally at the same time each day to ensure consistent therapeutic bronchodilation. This regular schedule helps reduce exacerbations, improves lung function, and enhances exercise tolerance and quality of life in individuals with COPD. The medication has a slow onset and long duration of action. Educating the client about consistent dosing is vital to prevent symptom fluctuations and reduce hospitalizations. Option B, incorrect. Clients should never increase the dose of tiotropium butya without provider guidance. This is not a rescue inhaler and is not meant for symptom relief during acute dyspnea. Increasing the dose could lead to cumulative anticholinergic effects such as tachycardia, urinary retention, blurred vision, or worsening of glaucoma, especially in clients with narrow-angle glaucoma where it's contraindicated. Option C, incorrect. Tiotropium should be stored at room temperature, away from moisture and direct heat. Refrigerating the inhaler is unnecessary and may actually alter the delivery mechanism or reduce medication efficacy. Option D, incorrect. Unlike short-acting bronchodilators or certain corticosteroid inhalers that may require frequent priming, tiotropium, particularly in the Respimat formulation, needs priming only before first use, or if unused for more than 3 days, or 21 days, depending on the device. Routine priming before every use is not recommended and could result in wasted doses. Here are advanced clinical notes for nurses. In mechanism of action, tiotropium works by blocking muscarinic receptors in the airway smooth muscle, causing bronchodilation. Use. It's part of maintenance therapy and is not effective during acute exacerbations. Common adverse effects: dry mouth, headache, cough or throat irritation, sinusitis or pharyngitis, less common, constipation, blurred vision, urinary retention. Critical nursing considerations: instruct clients to avoid getting the mist into their eyes, as it may worsen glaucoma. Evaluate lung function FEV1, peak flow periodically. Encourage hydration and oral care to reduce dry mouth. Monitor for signs of anticholinergic toxicity. Client education: never use as a rescue inhaler. Do not take more than prescribed dose. Rinse mouth if directed, especially if using multiple inhalers. Ensure proper technique for inhaler use, e.g., slow, deep inhalation. Now, let's look at the last question. A nurse is reviewing the medication reconciliation list of a client recently diagnosed with chronic obstructive pulmonary disease, COPD, who has just been prescribed salmeterol, a long-acting beta agonist, LABA, for long-term maintenance therapy. Upon cross-checking the client's medication list, which includes lithium, captopril, labetalol, and clonidine, which medication should the nurse report to the primary healthcare provider, PHCP, due to a potential pharmacologic interaction that may compromise the efficacy or safety of salmeterol therapy? A. Lithium. B. Captopril. C. Labetalol. D. Clonidine. Select the most appropriate action based on drug mechanisms and therapeutic goals. Correct answer is option C. Labetalol. Here is expanded clinical rationale. Salmeterol is a long-acting beta. 2-adrenergic agonist, primarily used in the maintenance management of asthma and chronic obstructive pulmonary disease. Its mechanism involves selective stimulation of beta-2 receptors in bronchial smooth muscle, resulting in bronchodilation and improved airflow. Labetalol, on the other hand, is a non-selective beta blocker with additional alpha-blocking properties. By antagonizing beta-2 receptors, labetalol can counteract the bronchodilatory effect of salmeterol, blunting its therapeutic action and potentially precipitating bronchospasm in clients with reactive airway diseases. Clinical alert for nurses. Co-administration of a beta blocker, especially a non-selective agent like labetalol, in a client with asthma or COPD receiving a beta agonist increases the risk of bronchoconstriction, compromises respiratory function, and contradicts the therapeutic goal of airway dilation. Nurses must promptly notify the PHCP to consider an alternative antihypertensive that lacks beta-blocking properties. For example, calcium channel blockers or ACE inhibitors. Why the other options are incorrect. Option A, lithium, a mood stabilizer used for bipolar disorder. It has no direct effect on beta-adrenergic receptors and does not interact with salmeterol's mechanism. Option B, captopril, an ACE inhibitor commonly prescribed for hypertension or heart failure. It works through inhibition of the renin-angiotensin system and does not interfere with adrenergic receptor activity. Option D, clonidine, a centrally acting alpha, 2 agonist that reduces sympathetic outflow to manage blood pressure. It has no known direct antagonism of beta-2 receptors and does not alter the action of salmeterol. Here is critical thinking tip for NCLEX. When evaluating drug-drug interactions, especially in respiratory pharmacotherapy, always assess whether a prescribed medication could inhibit or reverse the mechanism of action of another. In respiratory clients, beta blockers and beta agonists are often pharmacologically incompatible and demand careful monitoring or substitution. And that wraps up today's session on NCLEX Pharmacology for the respiratory system. I really hope these questions helped clear up some key concepts and made you feel more confident in tackling medication-based scenarios on the exam. Remember, it's not just about memorizing drugs. It's about truly understanding how they work, what to watch for, and how they keep your patient safe. If you found this helpful, just imagine what the full NCLEX crash course can do for you. With thousands of students already passing after enrolling, there's no reason to study alone or waste time guessing what's important. Don't forget, you can still grab 70% off for a limited time. Visit our website to enroll, and yes, the link is right there in the description box below. Lastly, if you haven't subscribed yet, hit that subscribe button and turn on notifications, because every single day we break down one high-yield NCLEX topic, just like this one. You're getting closer to that RN license, and I'm here to make sure you get there faster, smarter, and fully prepared. See you in the next video. Future RN.